Everybody, welcome to Commonsense Urology, where I go over common urological problems and offer a sensible approach to them. I'm Dr. Neil Gordon, and today's topic is treating prostate cancer. If you like what you hear and see, please consider subscribing and don't forget to click on the notification bell below to hear of many more episodes to come. It should not be a surprise to anyone that people want to be around for a good time and a long time. And treatment of any condition should not make them feel worse or live for a shorter period of time. And more importantly, they should not suffer from a condition, even if they have that condition. And therefore, as a result, it's important, particularly for men with prostate cancer, to treat them appropriately. Their wishes are very, very important, and anything that we can think of that might not assist them be around for a good time or a long time, or both, should not be considered. Now, you're all familiar with the Gleason scoring system of prostate cancer grading histologically. The easiest way to understand staging is using the old-fashioned ABCD system. Stage A0 would be a patient with an elevated PSA but a palpably normal gland. Stage A1 is less than 5% of a TURP specimen being positive for cancer. Stage A2 would be greater than 5. B stands for a bump, and that's what you've felt. B1 would be a lump less than 1 centimetre in diameter on one side only. B2 would be larger than 1 to 1.5 centimetres or something palpable on both sides. C stands for capsule. C0 would be no invasion of the capsule, C1 would be invasion of the capsule, and C2 invasion outside the capsule. D stands for dissemination. D0 would be an elevated PSA but with no cancer seen on staging scans such as CT and bone scan. D1 is lymph node metastases, D2 is bone metastases, and D3 is metastatic disease unresponsive to hormonal manipulation. The ABCD system is a very easy way for students, doctors, or any other healthcare professionals to actually work out a staging system to give an idea of patient management in just about any type of cancer. If you consider A as being localised and small and largely not always significant, B and C being palpable but one more extensive than the other, and D meaning dissemination, if you do those you'll have an idea of how patients can be managed. As an alternative though, in a more conventional way, there is the TNM system. It's a little more difficult to understand, but it's really the same things just transposed into TNM, which stands for tumour, nodes and metastases. And again, it gives the staging to help assist with management of the patient. Risk categories are an attempt to decide which patients are likely to have advancing disease in the future and warrant very significant active treatment earlier. Recently, grading groups have been created in an attempt to more accurately reflect disease performance. As with any medical condition, treatment should be based on life expectancy and life quality. In other words, to be able to live for a good time and a long time. Low-grade, small volume prostate cancers such as a Gleason 6, A1, do not always need to be treated. These patients can be managed in various ways but should be monitored at the very least. There are various terms used when patients are being managed conservatively, terms such as watchful waiting, which I don't like, active surveillance, which involves taking biopsies of the patients every 12 months to 2 years, which I think is extremely unnecessary, but that's a personal opinion. When you can use PSA, a digital rectal examination, and an MRI to assess a patient, I don't think you need to biopsy them, because they won't get any better. The histology grade will only go up, and the amount of it will only increase if any of those other parameters are changed. so I largely think it's a waste of time and money. So the need for intervention and the type of intervention depends very much upon the patient's general health and well-being, and the estimated life expectancy, and to be able to live for a good time and a long time, the patient's preferences. We do know that we can keep a lot of prostate cancers under control with hormone manipulation alone. And if a patient has a life expectancy of less than 10 years, sometimes that's a much better option than anything interventional. The two most common forms of treatment for prostate cancer are surgery and external beam radiotherapy. It's very important to have a full and frank discussion with the patient and with any support people he cares to bring along, such as family members. Brachytherapy, cryotherapy and other treatments such as high-intensity focused ultrasound and radio wave treatment are more focal in nature and can be carried out unilaterally. It's always important to bear in mind that the patient should be followed up long-term, with the object of the exercise being that the patient should live for a good time and a long time and should not suffer from prostate cancer. Radical prostatectomy may be carried out open, laparoscopic or robot-assisted laparoscopic. The results of cancer-free survival, continence and potency are much the same whichever procedure is used. On this model of the prostate, it can be seen that the nerves and vessels run laterally. In an axial projection, that would be in the 5 and 7 o'clock positions. So when the prostate is totally removed, the bladder is mobilized and moved down and anastomosed to the urethra before it enters the distal urethral sphincter. There will be some elastic recoil, and therefore the penis may be pulled backwards a little and apparently shortened. In this sample, you can see that the nerves have been cut. That is a non-nerve sparing procedure, and that is shown on the trunk of the nerves on the prostate specimen here, where it's been cut at both ends. In the nerve sparing procedure, only the nerves to the prostate have been cut, and the nerves to the penis and distal urethral sphincter remain intact. This shows a nodule at the right apex, stage B1, which would be suitable for radical prostatectomy. There are three types of radiation therapy used for the prostate: external beam, brachytherapy and HDR brachytherapy. EBRT patients may have anti-testosterone treatment prior to the procedure to shrink the prostate and make the target smaller. They usually undergo CT planning, and a small tattoo is placed on the abdomen to make it easier to aim the beam for the treatment. It takes 15 minutes a day, 5 days a week for 8 weeks, and it's important for the patient to realise that he is not radioactive afterwards. This is a T3-T4 lesion which has lateral pelvic wall extension and is more suitable for radiation treatment. The plan shows whole prostatic gland involvement with extension to the seminal vesicle. Under the circumstances, radiation therapy is more appropriate than surgery. Side effects of EBRT include tiredness, nausea, bladder irritation, incontinence, erectile dysfunction, bowel irritation, and bleeding. Brachytherapy is a type of focal therapy. For low-dose rate brachytherapy, small pellets are inserted into the prostate, smaller than a grain of rice. They then give off radiation around 2 millimeters radius to the pellets. The pellets are a permanent implant and stay there all the time. It requires a short stay in the hospital to have the procedure done, and they're inserted through the perineum using a grid just like for the transperineal prostate biopsies. High-dose rate brachytherapy involves admission to hospital, a general anaesthetic, and rods inserted into the perineum through the same sort of grid under ultrasound control, just like for the low-dose rate brachytherapy. Radiation is then given over a shorter period of time into the prostate. The patient does require a stay in hospital, and often the rods are left in place for a day or two. This is often combined with hormonal therapy and external beam radiation therapy as well. Various focal therapies can also be used in prostate cancer. Cryotherapy is a focal treatment for prostate cancer which can be applied to the whole of the gland or just to one side. It involves freezing using argon. The temperature is brought down to approximately minus 65 degrees centigrade and then raised back up and thawed out using helium, and then a further freeze-thaw cycle is carried out. The procedure takes roughly 1.5 hours in day surgery and is very effective for localized prostate cancers. This animation illustrates the insertion of the freezing needles, temperature monitoring needles, and formation of the ice balls within the prostate. The management of late-stage prostate cancer is centered around the fact that testosterone tends to stimulate it and should be reduced. Bilateral orchidectomy is not commonly performed. LHRH agonists are the mainstay of hormone control. LHRH antagonists are sometimes used also. The LHRH agonists can cause a surge in testosterone, and therefore it's a good idea to inhibit that by putting the patients on an antiandrogen such as cyproterone for a fortnight prior to starting. The antiandrogen is continued for a fortnight afterwards and the flare prevented. It is possible that if a patient has spinal metastases, then the flare can cause compression of the spinal cord and subsequent paraplegia. It is a requirement that antiandrogens such as bicalutamide, enzalutamide and abiraterone are used in conjunction with an LHRH agonist. These are given either subcutaneously or intramuscularly depending on the brand, and should be given 6 monthly. Strontium and samarium are radioactive isotopes which are given intravenously for the reduction of bone pain. Chemotherapeutic agents, docetaxel and cabazitaxel, may be useful in the late stages. Thank you for watching this episode of Treating Prostate Cancer. I hope you've enjoyed what you've heard and seen, and if you have, please give a thumbs up and please consider subscribing. Don't forget to click on the notification bell below to hear of many more episodes to come. Cheerio!